Okay, so the recording started. And I'll hand over to the Chair, Councillor Lucia Neves.
Thank you, Naz, and thanks everyone for your patience. Obviously, new room, new space, new technical challenges, but we love hybrid, so it works. We just need some patience with it, don't we? So hopefully, can I just check actually before we start formally? Can I just check everyone can hear online? And Beverly, yeah, that's right. If you could just direct that a little bit down, then there we go. Yeah, everyone in the room. Okay, so welcome to the meeting of the Health and Wellbeing Board. And as most of you know, but not all of you, maybe I'm Lucia Neves. I'm the Cabinet Member for Health, Social Care and Wellbeing and the Chair of Health and Wellbeing Board. So firstly, filming at meetings. Please note that this meeting is being recorded for live and subsequent broadcasts via the Council's internet site. So I want to welcome everyone to this meeting. Naz, have you had any formal apologies, etc.?
We've had one from Anne Graham, but also from Councillor Mike Carter.
Thank you, Naz. I also know that Councillor Brabazon is on her way, hot-footing it from another meeting, so she's given her apologies for lateness. And I know that we've got Polly here, and you are sitting in for Sharon Grant from Health Watch, aren't you? So welcome. So I'm not going to do a big round robin of introductions, but what I ask is that when you speak for the first time, please remember to introduce. Although actually we've got a few new people, but maybe we will do intros. I changed my mind. We'll do intros just because we've got a few new people in the room who might not know everybody so best. So I've started. Will, maybe you want to go and then we'll go online.
Afternoon, everyone. I'm Will May Maris. I'm Director of Public Health for Haringey.
Very well. I'm actually shadowing that today.
Welcome.
Hi, I'm Polly Frayne. I'm Programme Manager at Public Voice and I'm standing in for Sharon Grant, who represents Health at Haringey.
Hi, I'm Nazia Chowdhury. I'm Principal Committee Coordinator and Clerk to this committee.
My name's John Porter, Paralympian, live in Haringey in sheltered housing, major understanding of equality, diversity, inclusion, and major understanding of health and wellbeing also. Thank you.
Thanks, John. So, John, you're joining us as a member of the public today, aren't you? Which is great.
Correct, yeah. Which is I will stay radio silent until the questions are finished and everything's done. Then I'll highlight to you individuals what the problems I've incurred and you guys to implement it later on down the line for the correct change.
That's great. Welcome.
Yeah. Thank you.
Thank you. Beverly.
Beverly Tarker, Director, Adults, Health and Communities.
Sarah Sutton, Assistant Director for Place-Based Commissioning and Partnerships within Adults, Health and Communities.
Rachel Lissowa, I'm the Director of Integration for Haringey, working for the ICB.
I'm Akido Okerafo, Paediatric Registrar and Project Lead for ABC Parents in North Mid.
Welcome.
Linda Otre and Clinical Lead for ABC Parent.
Thank you. And then online, Cassie.
Hi, I'm Cassie Williams. I'm the Chief Exec of the GP Federation in Haringey.
Thanks, Cassie. John.
Good afternoon. I'm John Tomlinson, Senior Head of Commissioning, Brokerage and Quality Assurance at Haringey Council.
Gary.
Good afternoon, everybody. My name is Gary Passaway. I'm Managing Director at the North London Mental Health Partnership.
Thanks, Gary. Stephanie.
Good afternoon, everyone. My name is Stephanie and I am the Mental Health Project Coordinator for Tottenham Talking.
Jeffrey.
Good afternoon, Jeffrey Olsen, Chief Executive, Bridge Renewal Trust. Thank you.
Vida.
Hi, everyone. My name is Vida Black. I'm a carer for my son who has autism, learning disability, and challenging behavior. I chair the Carers Forum, and I'm also a member of most of the reference group.
Welcome, Vida. Sorry, forgive me. Tobias.
Hello there. Sorry I'm running late this meeting. Good afternoon, everyone. I'm the new clinical lead for ICB for children and young people. I'm just getting into my, I'm just running late for my clinic, so I should be on video in a few minutes.
Thank you. Thanks very much. And we've got Tom Leonard.
Hi there, I'm a GP in Haringey and I'm the clinical lead for the East neighbourhood for the Federation.
Thank you. Thanks very much. So welcome everyone. I don't think there's any matters of urgent business on the agenda today. Are there any declarations of interest? Questions, deputations or petitions?
None.
Okay, so straight to the minutes of the last meeting. Does anyone have any comments? Any feedback on those minutes? Or are we happy to agree that they are correct record? Yeah, okay. Silence. Yes, in that case. Thank you. So straight on to item 8, which is the Health Inequalities Fund programme in Haringey. And who am I passing to for the presentation?
I think you were passing to Paul Allen, but he is not here.
Yes.
I shall therefore speak to this and then do the introduction to ABC Parents. So apologies that it might not be quite as polished as it would have been otherwise. The main reason why we wanted to bring this item was to be able to hear a little bit more about some of the schemes that we have invested in and funded through the Inequalities Fund for Haringey. So I think the primary focus of this item on the agenda is ABC Parents and Tottenham Talks. Just to give people a little bit of context into the health inequalities work, this is an area of funding that the Integrated Care Board has made available to boroughs to allow us to have a focus on the populations, both geographically and demographically, that are experiencing the highest inequalities in our boroughs. So across North Central London, a decision was made to invest around 5 million, of which Haringey attracted 1.6 million for us to put into our areas, which are predominantly in the east of the borough. So the aim of the fund was to enable us to focus on improving health outcomes, develop more integrated partnership working and collaboration. We were particularly focused on making sure that our schemes were co-produced and had resident engagement at the heart of them. And it's really an opportunity for us to innovate, to think a bit differently, to work with different partners. I think the main thing to just focus people's attention on is we will talk about one scheme that has particularly been addressing issues for children and young people. We've tried to follow an approach that we've taken for our borough partnership overall, where we have directed funding towards Start Well, Live Well and Age Well. So it's just a kind of, they are a couple of examples that illustrate the type of way that we're working with Inequalities Fund. What I might do is hand over, because I think the main interest and the lessons that we'll learn will come from hearing from the projects themselves. And then I think that we will focus at the end on some of the cross-cutting issues that we're really working through. How do we demonstrate that the investment that we've put in through the Inequalities Fund is having impact? How are we using this as an opportunity to really innovate and to see whether co-production and co-design can help us to more genuinely reach out and improve health for those population cohorts where we know we often struggle with reach and engagement. So I think those are going to be the kinds of questions that we're going to come back to, but I think we'll do it best if we've heard first from a couple of the projects that have been trying to kind of take on and tackle those issues. So is it all right if I hand over to ABC Parents?
Okay. Not sure how much time that we have that we've been allocated.
Okay,
but
well,
I'll
so we
keep
want to
it
have some
brief.
time for, so if you could do, if you think you can do sort of 10 minutes on the project, does that sound reasonable? And then, because we'll want to then hear from Tottenham Talking and then have enough time for contributions and discussion and questions, that sort of thing.
Excellent. So I know that we've pre-shared the
you want
slides, but
to-
I can share it from here. Whatever's easiest. Okay, so I'll introduce myself. Well, we went through introductions, but my name is Kudo Careful. I'm paediatric registrar working over in North Mid, and my colleague here, Belinda, we set this up essentially 4 years ago now in response to the local need, which we're all sort of well versed in, but in particular experiencing the need as a parent, as an aunt, actually. And so one thing that I what really drew me into setting this up was the fact that my sister-in-law had a very premature baby, and having been a very high-powered HR manager herself, suddenly having a very sick baby in and out of hospital, she was then left feeling completely anxious and always taking her child to A&E or calling me to talk her into it or talk out. So it's that knowledge that actually if you've got someone who is very educated, who is well supported, when they have their own child, as a parent, when your little one's unwell, you are suddenly quite isolated, and that lack of knowledge can be really isolating, actually. And so ABC Parents is about recognizing the need and listening to what families tell us the gaps are. And I'll be able to demonstrate the extent of that co-production and collaboration in what we have built. So exactly as we're all very well aware of the inequalities that we're facing locally, and this was our starting point essentially. So North Middlesex Hospital, where we're based, obviously borders both Enfield and Haringey, and working in paediatrics in the A&E. My take on this in terms of what we were really looking to reduce was the A&E attendances, and so this is pre-pandemic, but about 40, we're coming closer to 50% of A&E attendances are avoidable. And by avoidable, I mean they're better, parents are better potentially supported elsewhere, whether that's GP, pharmacists, health visitors, and there's a crescent of deprivation around North Middlesex Hospital, and it is within the most sort of deprived 5% within England. And this correlates really closely with those high A&E attendances, especially by the under fives. So if we look at low acuity, so this is where parents, it might be diarrhea, vomiting, it might be minor head injuries. There's a whole host of relatively minor ailments that families come with their little ones, and it equates to about 10,000 children every year of under fives. So all of these essentially could be helped or dealt with elsewhere, and a lot of that is including self-care and having that ability to manage ailments themselves. And so they're the families that we focus a lot of our work on, and that recognition that health is only the 20% of what we do in GPs, in hospitals, in outpatients, but the rest of their health is everything else. So it's their education, employment, their income. And we know that these are drivers when it comes to attending A&E, about deprivation, fear, that lack of knowledge, often language barrier as well. And lots of families don't have that extended network around them, and they lack that confidence and both unaware and unable to self-care where appropriate as well. We often see that also families come at the last point when there are different conditions that their child is displaying and they don't recognize the symptoms as well. So this was my little nephew, and they often feared death, as she's put in this quote, and they wanted more parents around them. They wanted, both she and my brother as well, wanted that reassurance. And so with knowledge often comes reassurance. And so our core aims were to increase child health knowledge, parental confidence, and build sustainable communities. Because the first families that we trained recognized that actually they've got those same challenges, the same issues. And so being able to speak with them, and we built ABC Parents as a result of that, trying to build up communities. So we started small, We had that idea and passion and the absolute dedication and commitment from North Mid to support when we came to them with parents and said, this is what parents would like us to do. And we've been able to, Jeffrey's on the call there. He's one of our BCS partners, also with Breastfeeding Network and Every Parent and Child, and being commissioned by NCL, showing what we're able to do and working. What we do a lot of is that connecting local organisations with the families that we meet, such that there's that two-way street. They'll recommend families to us and we can then say, these are the services out there, which we're realising that lots of families aren't connected and aren't aware of. So at the crux of what we do, we deliver child health and life-saving courses to build up families' confidence. And that's what Belinda is absolutely passionate, and families come out there and absolutely buzzing from that increased knowledge and real awareness of what they would do if their child stopped breathing, if they were choking, and that really empowers them to learn more and to further engage. So we do these courses, we do breastfeeding groups, we hold community workshops. They're the neonatal intensive care cohort, given that they are already a fairly traumatized set of families. They have a peer support group which we help to facilitate as well, and we also do sessions out in the community for youth groups as well, to teach them basic life support and empower them. So we've been able to demonstrate from recent evaluation that parents are feeling more confident, and this is sustained confidence to both treat their child at home, to access reliable health resources, to deliver that first aid if required, both in choking and CPR in particular. They are sharing their knowledge as well. So we might just train a parent or a couple. We're asking them to share on, learn, and that's part of empowering them too. There is a video on here, but since it's a bit limited, this was a parent that basically relayed back to us at one of the community sessions that we do, that she had used the choking skills and saved her little Aaron's life as a result. So we are asking that parents, and we train them to look at online resources. In particular, we use one called What Not to 18, Healthier Together, which got trusted information. We use NHS UK. We're asking them to use 111, use their pharmacists, their health visitors, being able to demonstrate that actually there's a shift. Families are now accessing these non-acute, these community-based resources more often. They are self-caring. They are using A&E more appropriately. And so we were able to see for the families that did come to A&E, because we're not saying don't come to A&E, recognizing that actually more of them are coming when they actually need intervention. They need advice, they need support, and admission, etc. And so we're continually striving to empower families so that they do trust their own abilities and use what's out there. We do a lot of work from a public health perspective, and we've had the support from Public Health Haringey and Enfield from the very start of this. And so being able to demonstrate that as a result, families are taking up vaccination. They are now giving their children vitamins, vitamin D in particular. They are making changes to their households to try and prevent these both injuries and taking steps to avoid illnesses as well. And so we ask our parents, in terms of isolation, also mental well-being, what those gaps are, and 1 in 3 want ongoing peer support, and that is another way of us empowering them and addressing social inequalities. And then we also have champions, and 1 in 7 have requested to volunteer, and that helps to build up our reach as well, because there are lots of communities that we're not accessing. And so this is just a brief slide about the health inequalities. We work closely with the Salvation Army, for example, with their baby bank, being able to encourage families to ask for help, and we're able to arrange that support for them. Housing problems, mental health difficulties, these are all different ways that we reduce the stigma and are able to reach other families nearby. So these are our champions, and being able to connect them has really meant that we've been able to get into different communities. We've got a very multilingual and ethnically diverse group of parents, and being able to ask them what are the gaps, and working really closely with them has been an absolute source of our production. So I haven't got time to show you the video, but this is one of our champions who, as a result of the support, was able to come out of her mouse-infested property and being able to get that support, and is now in regular employment as a carer now. And as a single mum, they're the families that we really want to be able to support. And so we do have to look into sustainability. And so we're really fortunate and incredibly grateful for the ongoing input of other partners, and also being funded by NCL for a further year. And so we're working really closely with the hospital, building up our MDT model to be able to deliver more courses, working to build up our champions and our volunteers as well. And we've been able to share what we're doing elsewhere. We were fortunate to go to Copenhagen in May to be able to learn from other trusts and countries as to what they're doing with families in particular, and build on what we're looking to achieve. So we'd ask that all partners, and especially I see colleagues from GP Federation in particular, because we really want to work together to reach the families that need this the most. And then we're also looking to try and deliver our training in other languages as well, recognizing that they're often the families that are less engaged by what we're able to deliver. So that's me. I'm sorry if I went over time.
No, thank you. And I'm sorry to have got you rushing through. And I'll make sure I watch your videos later, and I recommend everyone else does that. Because I think those stories are always a really good way of understanding the work. So thank you. What I'm going to suggest, I saw that Paul joined us. So Paul, we're meeting ABC parents and Tottenham Talking, and then I might bring you in at the end if there's anything further you want to say, but Rachel introduced. So we'll hear now, I think, from Tottenham Talking, if that's okay, and then we'll do questions and comments on both of them after, though, if that's okay. So Stephanie, are you going to come in?
Yes. I'll just share my screen. So I'm Stephanie from Tottenham Talking, and Tottenham Talking is a project birthed by the Bridge Renewal Trust and BEH. Hopefully you get a better understanding of the project after this presentation. So I will be covering our project aims, referral processes, activities, our volunteer program, some highlights, a case study very briefly, some data, and our next steps. So these are our project aims. 1, to improve the confidence of people who experience mental health issues and their accessibility to peer, family, and community to support. To be an accessible program offering a range of activity for persons experiencing mental health challenges, for persons of all ages and diverse backgrounds. To work with local grassroots organizations to offer training and reflective practice peer support to support local community development and capacity, to provide community support for our participants in order to reduce hospital admissions, and lastly, to address and reduce stigma surrounding mental health within the community. Oh, sorry. Okay. So some of our progress up to date. So our quote unquote open date was November 2021. At present, we've had 270 referrals. Our referral processes are open to both organizational referrals in the Haringey Borough and also self-referrals. We have had 89 self-referrals to date, which we are really proud of, because it reflects that more and more people are becoming more comfortable with the idea of sorting for support independently. At present, we have 13 groups available ran in the community that cover a range of activities, which I will show you later. At present, we have funding through to March 2024. We have 178 people who identify as Black and ethnic, which we are really driving for, because we want the people that attend our groups to be a reflection of the people in the borough. Our gender makeup is 84 male and 148 female, with 1 non-binary person. We are doing our best to increase the number of males that attend our group. So far we've had 5 volunteers within our project. At present we have 2, and we've also had 4 trainees or students within the project. So I don't know why. Okay. So this is a typical example of our timetable. Our groups are usually held at Chestnuts Community Centre or the Hut, which is like a 5-minute walk away. Our groups are usually run by our peer support workers and co-facilitated by volunteers or other members of staff. We're doing our best to introduce more groups in order to attract a wider range of people. We do our best to be strength-based. So we look at the strengths of the people that we work with and encourage them to build upon their strengths. And where there are gaps, we encourage learning and growth in order to continue the rotation of the program and the growth of the program. So this is like a quick example of our volunteer program. Our volunteers are usually people that have attended Tottenham Talking as a participant. And then once they've been here for some time, if their interest is, if they feel interested in volunteering, then we go through the process with them, the application process, and then the HR process, DBS and all of that stuff. And then eventually they start volunteering. Our volunteers at the moment run baking groups and some of our talking-based groups as well. These are some highlights that we've had. For Mental Health Awareness Week, we held an art exhibition. We collaborated with some organisations within the Haringey Borough, and yeah, it was a great success. We had live groups running as well, and yeah, it was great. And we've also created a film, a service user film, where service users have been given the opportunity to tell their stories in expressive ways. And we've had a screening amongst staff members, and next month we are hoping to have a screening for the public within the community, and have a Q&A with the people that put the film together, which is something that we're really looking forward to. We've also had a staff away day, which happened last month. And prior to that, we've had a participant Christmas dinner. We have a fair coming up next month, and we will probably have like a barbecue at the end of August. We try to have an event where everyone can get together every few months, when and where we're permitted to. With approximately 300 referrals, we have had over 250 welcome chats which have taken place. A welcome chat happens when somebody expresses their interest in joining Tottenham Talking, and then we contact them between 1 and 3 weeks. We go through our processes, we get signed consent, and then they're free to attend any of our groups. On average, we can have between 2 and 15 people attend a group. Like I said before, we currently have 2 volunteers at the moment, and some small statistics that have been repeated. We've included a case study here, which is of a 20-year-old Black Somali Muslim person who was referred by the NHS. And I guess what was really outstanding about this person's story is that they said that they don't know what they would be doing. They don't know where they would be if they didn't discover Tottenham Talking and they didn't get involved with the community project. And a highlighting quote that stood out was Tottenham Talking is both convenient and helpful, as there are different activities every day. Everybody is really friendly and it feels like a community. And I feel like that is a direct reflection of what we hope to be. So our next steps are, we are trying to create a pathway for the 18 to 25 age group. And we are hoping to broaden the amount of people that come and the range of people that come into Tottenham Talking. So this will be in collaboration with CAMS. We've already started conversations around this expansion, and we're hoping to have groups running by September. And we're also in the process of creating a reflective practice offer to offer a monthly reflective space for grassroots organizations for 1.5 hours per month, and to develop training and workshop to address identified needs. We're also hoping to share our learning on how more organizations can become more peer-led and enable people to share their experiences while also connecting with people in the community. Oh, and that brings me to the end. I wanted to rush through it because I knew I was tight for time.
Thank you. Thanks, Stephanie. And I've had the benefit of meeting some Tottenham Talking workers when I've been at different events, and I've always been quite impressed by the concept.
Thank
you for that. There's a few hands up already, but I just want to give Paul a chance. So Paul, Rachel ably introduced this segment, but I don't know if there was anything that you particularly wanted to say before I open up for questions and comments and discussion.
Yeah, so apologies first of all for not being there on time. I was with residents, so I couldn't get away. And then my kind of Wi-Fi is also. Can people hear me? Because my Wi-Fi is going in and out at the minute. Yeah. I just wanted to kind of say that it's great to hear that the kind of the projects that you've kind of been alluding to during the course of the presentations are quite diverse, and you can see the kind of real benefit they've had for residents and patients, which is fantastic. I think the other thing I would say around it is when we were developing the portfolio of projects within the Inequalities Fund, we were really keen to make sure it was balanced between things that would have a long-term kind of impact, because some of the prevention solutions do have a long-term impact, with things that would actually help residents in the here and now. So one of the slides that is accompanied this within the main report talks about the idea of a balanced portfolio, about identifying where we've got prevention and where we've got kind of more kind of health self-management and strength-based solutions around things in a more direct way. And the reason for that is simply because that allows us to have a virtuous circle, to invest more in prevention and longer term support, and to move and mitigate the pressure that's on our kind of residents and patients firstly, but also our health system more generally as well. So it's great that we've, not just for these two projects, but we're also have been doing some evaluation for some of the other projects as well. We are really pleased about the progress that those projects are making more generally. So that's why we've continued to invest in 23-24. I think there's also an agenda item lit, or perhaps you've already covered it, around community chess, which I mean, colleagues in the council maybe would be better place to cover. So I'm just going to pause there because I know your time's precious.
Thanks, thank you, Paul. I've got a few questions, but I'm going to use my chair's privilege just to ask a couple of things that I think are broad, and I think they apply probably to these two projects and everything else that we do. And then John was quick to put his hand up, so I'll just bring in John, and then there are a couple of you online with questions. I suppose my broadest questions were about how there's some indications here of how what next for some of the projects and the work, and the sustained funding is a good thing, but how we mainstream, how we make it part of practice and take it from being a special project, which is really important, but how we make that part of the practice generally and how we work. And in particular with ABC Parents, I guess my question was also around how we connect with families who perhaps didn't have their children at North Mid, but had them elsewhere, but are in similar circumstance, how we connect with antenatal as well, and some of the other activities that might be happening in the community that bring parents together. And I'm thinking about NCT, which applies to some families, but not all, etc. And for Tottenham Talking, again, the same, how we're connecting in with some, how we're going to mainstream some of those, because to me, it strikes me that the work and the concepts are really good and quite logical, I think, but it's just how we make that part without losing it. Don't want to lose it, because it, sometimes when something becomes mainstream over time, but that you hold it, but at the same time it becomes part of everything that we do, and has quite a wider reach, because I'm struck that with Tottenham Talking, because of resource, it may be, and even the limitations of ABC Parents, but with Tottenham Talking as well. So that my questions are about that. How are we going to make this real and part of it? If we think it's working really well, how are we going to make it part of everything we do? Maybe I'll take a couple of questions and then come back. So I'll take John, because John's been waiting patiently for a while.
Dr. and Belinda, 3 points I can deliver for you. First point is, from my experience of 2 other organisations running similar to yourself, 111 don't work for a panicking individual, right? Whereby if you had a dedicated individual that's got the underpinning knowledge and understanding to calm the situation down, is my first point. Second point is your coordinators. I didn't know what you call them. I'm talking about your regional helpers. If they could set up coordinated groups the same as urology and gastro, right, whereby they got the underpinning knowledge, the workload on yourself, doctor, would be severely reduced in A&E by, I estimate, about 60% going by gastro and urology, right? If people understood what the criteria is, whether they need to attend and how they can help. The third point, which I thought was a lot more beneficial for yourself, doctor, and your colleague, was your coordinates to set up a social media, whereby Facebook, Instagram, and Twitter, whereby that was all set up, restricted to members only, with passwords and set up so it's restricted. No one else from outside can come in and troll, whereby it's not only a social meeting, but also a place for people to go. And reference getting your community off the ground in Tottenham, I can have a word with my scheme manager for a team morning on a non-functioning day in the hall, whereby you can bring your members to an environment we have not met for a 1 hour team meeting on, right, whereby they're not only looking at a camera or looking at a text, they've also got a place away from their own dwelling to encourage others to communicate. And my final point is to Stephanie, I don't know if you can hear me, I apologise, is I can come to your venue and tell people about my journey. And the last thing is, I would like to leave my data details with you for something I can do for you for Christmas. Thank you. Thank you.
Thanks, John.
Thank you, Miss.
Thanks. Thank you. So maybe I'll bring Gary and Tobias in, and then what do you want to say? Do you want to make? I'll tell you what, we'll pause there.
Okay. Okay. All right. So directly responding to exactly what you say about 111. From when we started this before the pandemic, people weren't using 111 and they didn't trust it, and so on. 111's done a heck of a lot of work, and there's been a lot of work that's been fed back from various organisations, and it has improved. And each time we do, of course, we ask parents what have their experiences been, and then being able to share when they've had good experiences has really helped our families to know that actually 111 is a great resource. Yes, you have to bear with the questions, but making sure that they're first of all calling it in the right situation. If it's panicking and it's a life-threatening, then 111 is perfect to say actually you need 999. Yeah, so that's where the algorithms are really important. And so we certainly take on that feedback and have been able to help share that with our families. So your next point about champions.
I
So
didn't
that's
know
what we
we
call our
called them. I
volunteers.
apologise.
Yeah. Our parent volunteers and champions. They've been absolutely critical from the very start. Everything from our uniform logos, we ask them everything, and they've fed into everything that we do. They also attend like maternity voice partnerships, being able to have that advocacy and that platform. And so any that you're able to link us up with would be great, such that they can represent from a parent voice. We're kind of inviting them onto interview panels, we're inviting them to board meetings, so that just like having yourself here, you get that real firsthand experience and another angle that isn't health, it isn't a professional. So definitely
it's like I've not heard of your organisation, but I do a lot of work with Mumsnet. I don't know if that's running the same parallels, but I set up a team morning with them at a different venue. You're based locally, that's why I'm prepared to put myself out to assist those members you got.
Fantastic. No, we absolutely welcome one.
Also, our current champion lead was our volunteer, so we employed our volunteers as well. So we're utilising them. They're not just a volunteer. We employ them and do other things, and I train them to build that to build their confidence, to be able to train other parents as well.
Great, and we love to hear people developing their skills and going on to work with organisations locally. So
yeah, no, we
encourage you. That was great work
in response to that. And then you made a point about social media. We do have Twitter and Instagram. Our Facebook we need to build up, but I wasn't aware in terms of being able to have a secure closed platform.
That's what I'm saying.
For our
The only feedback I can give you from Mumsnet, not disputing your organisation, is Mumsnet have got vulnerable parents similar to yourselves dealing with either premature late births or terminal births, whereby I went there as an advocate. I explained the scenarios I was in, which wasn't nothing to do with the opposite sex, but giving them a demonstration of where I've been, how I got to where I was, how I progressed. And I explained, if you put restrictions on who can join, the trolls won't be on there. The people with negativity won't be on there. And if someone's had a real traumatic experience, last thing they want on there serves you right.
Yeah, no. So we do have WhatsApp groups, and that's because we are very small and we are very local. We do have WhatsApp groups with families, and that's what our champions are looking to develop. Because you mentioned, Councillor, the NCT. So where we live, there isn't an NCT.
No, totally.
And that's where
appreciate that.
This gap, I guess, has evolved. And one of the things that my sister, who's is in an NCT group, she has said that sometimes she's felt like it's the blind leading the blind, because the children, they've all got children of similar ages. So what we've proposed and therefore developed has been that our champions have they themselves have had children, so they also have training and experience. They hold a group of local families such that they will be able to be that voice of experience, if you like, if there are questions that come up that the other parents aren't able to answer. And then that's another way of us getting feedback, because we've been invited to feedback on like the Henry Project and helping with immunisations programs. So being able to have that access to local families such that they are helping to develop other services has been really good way of building their confidence and knowing that their voice really matters.
That's great. And we know that some of those things also have barriers, because NCT involves payment as well and all sorts of things. So totally with you on that, but just feels really important to build as many those different connections and reach as many people. I just wondered if anyone had a comment about mainstreaming, and I can see, but maybe Beverly wants to come in, but let me bring Rachel in, and we've got lots of people wanting to.
Just specifically on mainstreaming, I mean, it's a very good point, and it's really challenging, isn't it? Both operationally to go from something that's project, but and also just to translate what are non-recurrent funding pots into something that's mainstream. We have got examples. It just brought to mind an example that has worked really well with the council. So I was particularly thinking about a programme that was run to provide speech, language and communication, particularly amongst within a children's centre and nursery, which really modelled how we move into universal support for speech, language and communication. And what we were trying to do was to test and see whether we could do that as a way of reducing people's reliance on having EHCPs as a way of getting that sort of speech, language and communication input, which often happens very late because they spend their whole time going through that process of trying to get the EHCP. And we heard from that at Startwell board, and it was incredibly inspiring. And one of the nicer things about it is that it then served as a blueprint, and that we've constructed a business case between the ICB and the council for how we then actually create, and with Whittington, that provides the speech therapy, of how we move towards the universal model. So it was a real test that has then translated into practice, but that has taken a coalescing of a lot of both strategic and practical funding alignment to make that happen, from the Whittington, from the council, from the ICB. So I guess what I would say is we are really mindful and trying to do that where we can, and we need to do that, I think, on a case-by-case basis of saying what are the opportunities for making these ways of working part of our mainstream of how we offer services. I'm sure people like Gary will have more to say and think about that. So just an example of one of the types.
Thank you. Thanks. And I suppose my chair's comment on that is that's the argument for different ways of models of funding, which are not about the people in this room, but are about what we bat upward, about what we want to see more of, that's going to really have impact and going to reduce pressure on acutes, but most importantly, going to support residents best and secure better outcomes for children and families. So I know Gary had his hand up. That Gary was next on my list, even though he left, but luckily managed to come back. So Gary, do you want to go next? And then I've got a long list of hands.
Thank you very much, Chair. I've joined on my smart device, so hopefully you can hear me okay. My connection just went, so I'm sorry I didn't catch a lot of the comments there, which is unfortunate. First, we'll just say a couple of great presentations there, so thank you. Thank you very much, Dr. Akudo and Stephanie. I just want to talk a little bit about the project that I know more about, I guess, which is Tottenham Talking. I can see Stephanie and Jeffrey on the screen. I think the first thing that I was going to say is that I think this is evidence of how collective collaboration, working together between the National Health Service, secondary care providers such as ourselves in BEA, or the North London Mental Health Partnership, I've got to get used to the name, and ourselves with VCS partners works really well, and the benefit that it can have. I've actually joined a few of those sessions, so it was lovely to see the pictorial, the infographic of the timetable there. I've joined several of those, in particular the art sessions, which I thought were amazing and a really great forum. But so many of these things are, and I probably just wanted to zoom in, I guess, on a couple of things that have been raised. So one, it was quite powerful, some of the feedback, Stephanie, and I've heard it before as well, in terms of our residents, the population who sometimes feel like they've got, they didn't know what else to do, and I've also heard they didn't know where to go, or who to be guided to. So I think the fact in itself that we have these networks, and that we have this and we have that, which is being provided by grassroots organizations in the communities that we hold dear, that in itself is fantastic. And obviously broadening that, profiling it and getting it out there and spreading the word, because quite often it can be word of mouth. That's a great thing in itself. And I suppose the other thing I was going to pick up on, so that was your point, Stephanie, the point that Paul, at this point, I lost my connection, but Paul mentioned the word in terms of sustainability, or at least that's the ethos that I picked up from it. That's really key. It's not just to fix it. It's not just a quick fix. It should actually encourage some kind of prolonged support or network that's going to lead to some kind of flourishment. You get the quick fix if you have to go into A&E for something that needs to be dealt with very quickly, but the longer term solution is about ongoing stuff that we work together to try and deliver. And I suppose with my purely mental health hat on as well in this scenario, for me, this is a great way of ensuring that our population has a preventative and supportive network that hopefully can lead to them avoiding a crisis presentation or leading to a crisis, because that's what we needed. That's what we need to be doing. And I think by working together on this, focusing on the inequality agenda, it is a great thing. So I think my own feedback was, long may it continue, and I suppose the next stage to think about how we can do this more, because as we progress, and obviously as we enter a world of financial challenge, we need to be using and utilizing and all working together to try and resolve these problems. I think this is a really good example of how well that works. Thank you. Thank you.
Thanks, Gary. I think that's really helpful. And I guess the other conversations we're having are just about the flow of people and pathways of people between services, and particularly I'm thinking about mental health. So we're in a bit of a journey, aren't we? All together, I think that's right on that, so that we're making sure that at the right time people are getting something that's appropriate and that they feel held and supported through everything they're going through. And there are highs and lows on those journeys, aren't there? Jeffrey, you wanted to come in?
Am I next? Yes, I am.
Yes, you are.
Okay. Thank you, Chair. Again, mine is actually a comment rather than a bit of noise. Second, closing the window. It's not a question, it's just a comment really, and following up from what Gary said. So thank you, by the way, Akudo, and thank you, Stephanie, for that. And thank you, Gary, for your comments as well. So Chair, is not so much about mainstreaming, because I think mainstreaming can happen at different levels, isn't it? You can mainstream the actual services as well. Or you could, as I want to suggest here, mainstream the way of working as well, as we are seeing in this project. And you might call us, what makes these two particular projects really work really well. In my view, I think you need the passion there. And if I can take Akudo as an example, she's a parent first and a professional second, and that comes out in the way all of this has been done. And as you may have known, for a long time, it was just a volunteer-led project. So that's really important. And then how you bring the peer element to it, people with the lived experience. And we've got champions and peer workers in both projects, and that is working really well. And that's, I think, where you then build on, Paul suggested something about building on strength and the assets that are there, and your co-production and all of that stuff we talk about. The funding is important because a lot of this, even Tottenham Talking, it started about 4 years or so ago, and then it went, there was no money, then it came back. So the funding and sustained funding is really important. I think my only, first of all, thank you, I think, to Paul and Rachel and all the others ICB colleagues, but we could do more in the sense that it's a very annual thing, the way it's decided and the way it's run, and that's really tough to retain good staff. But also, residents are fearful, next year, will it be there, will it not be there, and so forth. So there's something about how can we, if we have the money, how can we take a longer term view, I think, of how we do the things. And I think my last point really is on the partnership, why it works. And it's very clear in the two projects that it's got all our statutory friends and all our voluntary sector, and got resident right in the middle. And I think genuine partnership there is important. And I probably would say this doesn't apply to all of the healthy neighborhoods projects. So I think there's something there to learn here if we can bring it there and make it more of a equitable and level playing field for all the partners involved. And I don't have time, but I could go on about procurement, how some of these things are done. But Chair, I've talked about this before, so I won't. Thank you.
Thanks, Jeffrey. And I think you're right. And so I think when I say mainstreaming, maybe what I really mean, you're right, because I think you've elucidated it there. What I mean is having more long-term funding, having more consistent funding, so that it provides that security, and increasing access, more people to be able to benefit across our most vulnerable and most needy communities. Actually, I mean, I think Tottenham Talking is a great project, ABC, they're great projects, and I'd like more people to be able to have access to help and support like that. Because when they work, then if it's good, then it should be working for lots more people. And I think that is about funding. And yeah, I think I take your point. It's also about how we commission these things. how we make it all happen. So yeah, thank you. Very useful comments. Cassie, you were next.
I'm mindful that Tobias has got his hand up and he's number one, but I'll come in and just.
No, oh, apologies. Actually, Tobias, I completely missed
Fine.
you.
I'll wait.
Yes, I'll take
That's
Tobias.
okay.
Sorry, I don't know, and
That's
I've
okay.
actually down. It's so hot in this room, I'm afraid. So it's completely disintegrated my brain, I'm afraid. Apologies, everyone.
That's
Tobias.
okay.
Yes.
It's okay, I'll forgive you. It's okay. First, I just want to say, both projects sound fantastic, and Akudu and Stephanie, they're really, really interesting projects. And I'd love to meet with both of you separately to discuss how, as a GP, we can integrate this better into primary care, and how we can better educate GPs and those working in primary care to push towards your services. Akudu, I just wanted to ask, obviously, hi. I used to be Akudu's SHO when she was a registrar in North Mid in my GP rotation. I just wanted to ask if you had any more details on the demographics of the people using your ABC parents. I know they're based mainly around North Mid, but I just wanted to know if you had any more information on more specific demographics of those using your services. Just more out of curiosity.
That's a bit. I think it would be good to talk a little bit about data, because another question I'd had, which I think complements Tobias's, which was around the number of families, and then what you talked a little bit about outcomes, but I suppose we could talk more, and we don't have time here, but maybe that's something we could share a little bit more on.
So in terms of where we advertise what we do, obviously we're looking to the east of the borough, knowing that that's where the more the families that suffer deprivation live more. But we also, with our outreach and engagement officer, we will advertise in barbershops or advertise in local pharmacists, in supermarkets, in places that and churches and places of worship that we know that families who are from across the demographic. But we do want, and we're happy to be able to share that from our recent survey, we had just in terms of when people, and it does seem quite unfair when we're looking at just BAME communities, or we're looking at white versus non-white in terms of who's being reached, because we know from a deprivation point of view that it doesn't matter the colour of your skin, everyone's been really hit by the cost of living. But we do know that there are certainly certain communities that have got far less access to health, and their outcomes are worse. So I did make a note, because I thought I might get this question. So from our recent survey, we have 76% of non-white British, non-white Irish users, and that goes right across. And so when we do ask for their data, and this is important from a reporting perspective, we will ask them to, according to the kind of public health and certainly how you classify in terms of Black African, Caribbean, in Chinese, Indian. And so we are able to demonstrate across, and I did have to take out a few slides compared to what I'd presented to our recent steering group, but I could share with you, I could show you the screen, certainly from the recent surveys that we've done with our families in terms of long-term, the ones that have given us their feedback. Let me just collect the right evaluation. So I'm hoping that this comes up. So in terms of where sort of the first column is white British, white Irish, and then we've got any other white background for which in particular families from Romania, Bulgaria, and so on will respond in that column, if you like, and that is one of our is our highest group. And then we have Black African, Black Caribbean is the next peak, and then within our other, we can't sort of determine what that is, but we are able to demonstrate that we are reaching across the board. But one of the, just coming from the Family Hub meeting just now, the Orthodox Jewish communities, we haven't been able to arrange to have teaching for them, but we have been able to respond where people have got in touch and said, actually, we've got families that don't necessarily want to mix with other groups. And so what we have said to their teams, bring us if your groups are happy to come to a building where we are and we just train their cohorts, then we can do that. And we've done that for Rise, which is a group run by the Somali families. And we've done that, I think, 2 or 3 cohorts for them. And we're doing that on a regular basis, just having had met up with them just now at the Family Hub. So we're arranging for in September going forwards as part of the Family Hubs, so that it's buildings, and all the work that we do is in buildings that serve other purposes. So rather than it just being, when we started out in just little church halls and so on, we want to be within hubs, we're in community settings, such that they can then get the additional support from, whether it's citizens advice, connected communities, all these different organizations, the things that Bridge Renewal connect families with, for example. So we're able to show that we are both in our outreach, finding families from different ethnic backgrounds, but then also for the families that then become champions, the ones that then become volunteers, that's across a mix. And so our breastfeeding champions, for example, out of the 11 who got right through their training, they speak 10 languages between them. And so that's a really powerful thing for us to demonstrate that actually they're then able to build up their trust and use their networks and supporting families in their own language, which means that certainly when it came to vaccinations, and there are different cultures that did not want to anything to do with vaccines as a result of the pandemic and COVID and so on, building up trust through families that speak their own language as well has been really important. So I'll pause there, but
thanks, Akudo. And that feels really important, that spread, given the conversations we've had about Black maternal health, for example, here, concerns we have and how that might translate with people's early experiences of parenting as well. And really also great to think about that connection with us, with the council, and because we're on the same page in those, that in working closely with those communities, seeing our communities and working at that really close understanding level, and working in people's own language and with their own conventions. Beverly has waited quite a while, but I've got a long list. Do you want?
I think Cassie was.
Yeah, exactly.
Obviously.
Yeah, absolutely.
Exactly. It's an aging topic, isn't it?
Yeah, absolutely. So let's bring. I've got Cassie, and then Stephanie, then Paul, and then I'll bring you in, Beverly. So I've lost track of that.
Actually, can I come in before Paul? Because I think Paul may be able to respond to what I want to ask.
Okay, perfect. Yes, we can have a negotiation. Absolutely, Cassie.
Thank you. Yeah, brilliant presentations, really fascinating. I was particularly minded with the ABC parenting work, just how we support making sure the message is out there and generating the most referrals. I guess there were two specific things in my head. Just I'm sure you get referrals through from ED. We also have a primary care service in ED, so some of the children, and they do see children, so there's quite a number of people who see children who are a GP, but it's slightly different. And I just think it will be important to make sure that if referrals need to come back from there, that loop is joined up, and happy to discuss that if it's not already happening, and it might be. But also just to really think through how we do the referrals. And I guess it's that wider challenge of I do feel for general practice sometimes that they need to have an immensely encyclopedic knowledge of everything that's going on and everything that goes on and changes. And I know we have NavNet in Haringey, and with social prescribing link workers that can help support that. But it would be lovely to be able to promote some of these things. But I wonder if not here, but elsewhere, we really need to think about which would be the ones we want to amplify and how the heck do we do it, because it's not easy. But if we're going to support that real strengthening of our community and building that community network, we probably have to figure out how to do that bit a little bit better.
Thanks, Cassie. And I feel like, oh, you've kind of come close to one of my other favourite hobby horse topics, so I'll say it, which is that conversation about how people know what there is and where to find it. Sorry, I'm nothing. No, we're lying. Everyone else in the room is like,
working up,
So I think that's about everyone in this room.
Yeah.
It's about NHS services, the council, and everybody else in between. And it's a big ask from residents. From the council side, we're working on a whole new website, and you'll you'll not be surprised to know that I've been in to say, okay, for when we get to a place when we could look at how we share things online, will it all be able to do all the things in the back end, even if phase one will not have it? And I'm reassured, having had a presentation, that it will have the nuts and bolts that we might need for the future. And of course, online's not for everyone, but good online can mean someone can sit with someone and take them through what's there and print things out for them. So I think it could be an answer. So thanks, Cassie, for allowing me to talk about one of my favourite topics. I'll buy you a coffee later. Stephanie.
Thank you. I know we've moved quite on from the mainstreaming question that you had, but I just wanted to echo on what Jeffrey and Gary were saying in terms of like our efforts to become more mainstream are quite reliant on our collaborative work and building pathways with like St. Anne's. But one thing that I've noticed, or we've noticed as an organization, is that there's a lot of stigma associated to mental health, which is not news to anybody. And it's like undoing that work and trying our best to destigmatize, which looks like collaborative work with different organizations, which looks like going to community events and making our presence be known, which looks like highlighting our niche in working with peer support workers and sharing our learning to other grassroots organizations. That enables us to do our best to like make our presence be known. We're also working on building trust of the community, but a lot of people hear mental health projects and they run away. And so building trust looks like collaborating with faith-based projects or gender-based projects and doing
the down arrow till it goes down below.
Sorry, John.
Sorry,
please. Sorry about that, Stephanie. We're desperately trying to, in the room here, make it a tiny bit cooler. So we've got some tech people working on the aircon. Sorry, Stephanie. Please go ahead.
It's okay. So yeah, doing the groundwork, which we have been doing, and that will show within itself within time. I believe that, you know, with our efforts so far, i.e. with social media and our already existing collaborations, we've already increased our reach by so much. So regarding mainstream, I feel like we have the ball running, but we're also aware of more groundwork that we need to do to add to our expansion. That's what I wanted to add. Thank you.
Thanks, Stephanie. And I attest to that because I've been to so many events and met people from your team. Actually, one particular person I met quite a few times, and it's great to see that. And so clearly you're on the ground in a lot of places that councillors are at. So that's a good start. So thank you, Beverly, and then Paul.
Thanks. So Akuda, Belinda and Stephanie, fantastic presentations and you know, really remarkable outcomes that you've achieved in what I would feel is a relatively short space of time. But I suppose I want to return to the themes of prevention and mainstreaming, or should I say how we can develop these projects from being projects to actually just part of the way we do things. And I've been in some earlier conversations, and one of the issues seems to be, we know the money is tied up. We know funding, additional funding is the key to sustainability of projects, plus all the other sort of developmental collaboration and pathways, but funding is a key lever. And we know that the funding is tied up in acutes. But I've been having conversations, some national conversations where we've been charged or almost accused, not we Haringey, but local authorities and the system more generally, around being very poor at demand forecasting. And that triggered a thought in me as to reason why that should be. And we know during the period of austerity, a lot of the analytical support that you used to get in local authorities were kind of swept away because of funding constraints. But there is just something around how we might negotiate to build that evidence base to actually be able to demonstrate, well, actually it's worth investing in these sort of projects such as this. And I know Paul is a guru at analytics. That's why I said he should come in after me, because I would really like to hear how far Paul thinks we've got as a system in terms of being able to develop that evidence base, even if it's not just within the sub-region, but other projects like this may well be going on regionally or more nationally. How can we bring that data together to actually present that evidence nationally to make the case to policymakers and government that actually more money should be spent on the preventative side of things? And that's what all these projects, that's the strong theme of these projects. And in fact, how can we actually demonstrate that they actually reduce in demand, whether it's tendencies at A&E, whether it's in that sort of revolving mental health space. So that's my kind of question about how we can just really motor ahead with this sort of really remarkable pieces of work.
That's right, and sometimes we're worried that everyone's doing brilliant work, but we're not shouting about it enough. We're not talking about those outcomes. That we can't afford to hide our lights under bushels, because the money won't flow through. That's not a criticism. So clearly you've got a great presentation with good evidence. Anyhow, I'll bring Paul in, and I'm not sure, Stephanie, is that a legacy hand, or did you want to come in again? I'll bring in Paul first.
Yeah.
Yeah, I'm a bit shocked to be called a guru at anything. I think, yeah, anyway, leaving that aside, I was just going to say that thank you for the build-up there, kind of Beverly. I think we've been proposing an approach, and I can see Ruth's online as well, who's my kind of director in the communities team, which is kind of should allow us to kind of formulate in a systematic way how we can build an evidence base around the differentiation between early prevention through to secondary prevention and so on, and to see what the impact is on particularly our underserved communities and groups, and to understand where the resources are currently going as well. So the argument that Ruth and I make a lot to, successfully, I've got to say, to the ICB is we think that actually investing this money in the underserved communities and groups is a good investment for the wider system, because there is a greater level of need and therefore a greater opportunity, if you like, to mitigate kind of healthcare or social care utilisation. Doesn't that seem the right thing? So technically it's called something horrible called proportionate universalism, I think, in terms of it just basically means you put more investment in the areas of need. So part of the evaluation of the programme when we're working through will pull that together, but also we've got our eye on pulling that together more globally around it. I think we met with some colleagues in different ICSs across London, and the general feeling was that we had some advantages around our data management piece that they didn't have, and they had other strengths we can learn from as well. So I definitely think that, and we've reached out, Beverly, just to reassure you on this, to Haringey Council as well, to be one of the partners to do some of that work as well. Like I see, Ruth's going to come in and talk about that as well. So that's what I would say about the evaluation piece. It's a work in progress, but I think we've got every opportunity to understand demand forecasting and how we can mitigate that in terms of compression of need. The other part of the kind of the reply I wanted to put together just really briefly is about the maintenance thing. I think it's absolutely critical. And you've heard one or two good examples of how that could be maintained in the kind of mainstream thinking. Jeffrey's absolutely right in the sense that this isn't just about expanding on what we're already doing with a project. It's also about the approach and the way of working. So just to give a tiny example of that, which is really powerful, I think. We did some work with the Turkish and Kurdish community, which Cassie and the GP Federation have also led on as well, and done really well around improving long-term conditions as part of our kind of healthy neighbourhood work. And we basically had a longer conversation with some community researchers in the Turkish and Kurdish community to get under the skin of what those kind of healthcare needs were. That was really successful. But then it immediately sparked another conversation about how do we bring in and think about shaping a solution around pain management services, which isn't funded through the Health Inequalities Fund for Whittington. So they were immediately saying, can we have a joined up conversation about some of these things? So I'm really delighted about the progress that we're making on this space on the NHS side in particular, because it's kind of, I think it's helped open people's eyes up in the NHS about the power of doing this and the power of co-design and co-production. So just a final thought is just one of the things I didn't mention earlier was some of the learning from the program so far, and Jeffrey touched on it around the procurement. I don't want to go through that loop again, but we have made sure that we kind of make sure that the financial flows are going to run a bit faster for this financial year than they have done, to basically kind of protect some of our voluntary sector partners who aren't in the same sort of financial position as the the statutory sector partners as well. So that was a commitment from me, and it's a lesson definitely learned from 22-23 evaluation. I should have said that earlier actually, so apologies.
Thanks, Paul. I'm really conscious of time, so but let me bring Ruth in, and then I'm going to bring in someone who hasn't spoken yet. So Ruth.
Thank you, Chair. And for those of you that don't know me, I'm Ruth Donaldson. I'm the Director of Communities, so overseeing the Inequalities Fund. And sorry I'm late. I just wanted to echo what Paul and Rachel were saying, which is what we're really keen to do is exactly what your previous colleague was suggesting, which is set out, if you like, the opportunity cost for not investing in these schemes, rather than just demonstrate that we think this is the best use of resource. We're really keen to come together either as a borough partnership or as a wider NCR system and say, actually, if we're not investing in people with severe and multiple disadvantage, who we know cost the health service 10 times as much as an average resident, then we are missing out, and that is not a cost-effective use of our health resource. So that's the case that Paul has done a lot of work on building, and it would be really good to maybe bring that back here or talk with colleagues outside of the meeting on how we convene that wider conversation about not just inequalities funding, but the wider funding that is available in the system, and how we make sure that all of our funding is proportionate to need, because we know we have particularly high needs in some communities in Haringey.
Thank you, Ruth. And my dad, if it's not part of that work, just reflecting on the fact that you're translating volunteers into employees, that kind of social value side feels really important. I know it's something we talk about quite a bit in the borough as well. It feels really important to value that and understand what that means in terms of outcomes for those individuals and for their families as well, and how we measure that. I was only going to bring one more person in, and it was going to be Polly. Okay. But I'm sorry, Zena, because we've really overrun on this. I mean, I think we could, such an important area, we could talk all day on it. Polly.
I'll make it quick then. No, it was just a couple of thoughts from the discussion from the beginning. Something that John said about welcoming you to kind of a tea party to your scheme. Because I work with older people in Haringey, it feels like there's maybe an opportunity for some intergenerational work. And if you think about volunteers, they could be retired volunteers who have got medical backgrounds. This is a very untapped resource, but then I think that doubles the impact, because actually those people in turn will benefit from integrating into what you're trying to do, because we're working a lot with loneliness and isolation at the moment, and people feeling they need a sense of purpose. So that was one of the thoughts. And then the other one was with Tottenham Talking, was how we feed into each other as VCS services and partners outside of the statutory services. And Stephanie was saying that Tottenham Talking find it hard sometimes to integrate people into the idea of going into a mental health service. Well, we have actually introduced quite a few people into Tottenham Talking because they've come via a route, a cafe route. So they came to our cafe, they chatted, Tottenham Talking came in, this is at Chestnuts, and a number of those people that just dropped in with no intention of going to a mental health support group suddenly found that that was quite palatable, and they moved on through that. So we can all work together to create a comfortable, soft handover pathway between our services.
Thank you, and thanks for bringing in one of my current favourite words, intergenerational, and just thinking you're building on all those conversations we had at the recent loneliness conference. So really good, great, good things there.
We've had some elderly ladies who have knitted boobs for us for our breastfeeding group, and we got a delivery of 20 the other day because they all got together, and one of them messaged to say that actually she now feels like she's got a purpose, exactly what you said, that she was feeling pretty useless and doesn't have grandchildren of her own, and being able to open those doors.
But that should be an outcome for you. because you are actually.
Yeah, I think that's great. I honestly, I'm really sorry. I'm going to have to move us on because we won't have enough time for the other items. But you might be able to weave in your comments into the other comments you're going to make in the next sessions. I just want to leave this section knitted. Thank you so much for coming to talk to us about the projects. And I look towards more mainstreaming and hopefully more resource for this really important work. So thank you, everyone. I'm going to move us on to item 9, which is a borough partnership update. With Sarah and Rachel.
Yeah. Just are you staying for?
I don't know.
Should we say?
Up to you, basically. Don't.
Or
I
we
mean, I
can
know.
watch the meeting later.
Yes, absolutely. So you could leave us. That's fine.
We have today with lots of different things. Thank you and lovely to meet you all.
Thank you so much. And we'll make sure through the power of NAS, etc. We'll make sure we connect people. And do chase me or NAS if you don't
leave these with you.
those contacts. Thank you very much.
Yeah. Thank you.
So I just wanted to bring a bit of an update on where we've got to with the borough partnership, because I think it's been a while since we had that on the agenda. Around November and December time, we had a big round table of the borough partnership executive, and had previously done quite a bit of development work. And we just wanted to reflect a bit on how we've tried to take the themes that came out of that and develop our structures and ways of working in response to it. One of the things that came up was about being really clear on our outcome focus. So just being really crisp and having a shared understanding of what are the outcomes that we're trying to improve by working together as a borough partnership, and having a limited number of strategic aims for each of our different partnership boards and areas, which would then be underpinned by delivery plans and agreement on how we're measuring impact. One of the points that Beverly made was just we always come back to what's the point of us all working together, and the point is because of our shared absolute commitments to focusing on prevention, early intervention, and integration as an enabler. So we're really making that the heart of everything that we do. Mental health is really what we've identified as being the area that we will try to take as a litmus test of that approach. If we all really do focus for children, for working age adults, for older adults on mental health and well-being, and improvement in mental health and well-being and early identification support, that is our key unifying factor for the borough partnership. Which is not to say that we've not got other things we're focusing on for Start Well and for older adults. It's just that that's our kind of golden thread. We also recognised that it is really difficult. It's difficult always, and it's particularly difficult at the moment because our resources are so strained, where we have patients who need to move across the kind of boundary of different services and agencies, between VCS and statutory sector, between council and NHS, and so we need to have more focus on that. We also didn't have at the start of the calendar year a way of developing clinical and professional leadership within our borough partnership, because we were just in transition of clinical leadership, and we also had a recognition, I think, that we weren't necessarily, we had strategic groups that met and had lots of conversations about our strategic ambitions and aims, but we didn't necessarily have, and I don't think it's just us, we were just kind of recognizing it, that getting that translated into the way that somebody working in a specific service is working was really difficult. So we talked quite a bit about a strength-based approach, for example, in social work. We talk about it a lot in the strategic context. Are we talking about it as much in operational meetings? So what we've done since is we have agreed outcomes for each of our partnership boards and driver diagrams that just set out how we're going to try to get to those outcomes. We've started and we had a really good piece of work that Will and team did around how we'll measure outcomes and indicators. Both of the sort of some of the outcomes take a very long time to affect, so that we also thought about what are the measures that will show us we're getting in the right direction. We've done a lot of work to map subgroups and make sure that we've got working groups that are taking forward our kind of delivery areas. And on that interface point, one of the other things we've done is we've set up some senior, or we're in the process of setting up some senior operational groups to really look at those interfaces between agencies. So step up, step down from care, and really have collective focus on that. On the clinical and professional leadership, fabulous to see Nadine just joined exactly at the right moment. We've got clinical leads for Start Well, Live Well, and Age Well, and so we've got Tobias, who's, for example, our Start Well clinical lead. And what is really we are unique in having is that Cassie and the GP Federation have appointed neighbourhood clinical leads. So that is also really helpful because Thomas is here as the East Neighbourhood clinical lead. So you can have that interface between somebody who's the clinical lead for older adults speaking to the person who's the neighbourhood clinical lead. And we've also, I don't want people to think we've just been shuffling around with our structures, because we really haven't. We've also all the way through been focused on delivery. So Start Well in particular, one of the things that we've really coalesced is a vaccination and immunisation delivery plan, because we are our uptake for childhood vax is much lower than it needs to be. And we've done the work that I mentioned just before on speech, language and communication, moving towards that universal offer. For example, for Live Well, loads of work that Gary and team have been doing on our really just recruitment and bringing more people in to provide community mental health services. Age Well, we've been particularly focused on getting an operational group up and running, because we were having and continue to have real delays in our residents getting out of hospital. So we've had a real focus on improving that discharge process with a huge amount of change that's happened in that adult social care to enable that. I won't go through all the others of it. The only other kind of key thing that I do want people to be aware of is that we had always in Haringey had a lot of focus on long-term conditions, but we hadn't necessarily reflected that when we did a kind of diagrammatic representation of our borough partnership work, and we've changed that. We've got now a much more visible focus on long-term conditions, with a long-term conditions group that is clinically chaired, that is going to report into a joint meeting of Live Well and Age Well, because you can't sort of put it in a box. So we'll have a joint meeting to provide that oversight. So I think those are some of the things that that you would notice. The other thing is, and we've been talking about the health inequalities work that we've been doing. We've got a group that is particularly looking at our work to impact on inequalities and neighbourhoods, and we've just renamed that as the Inequalities and Neighbourhoods Board. And we are now moving into a bit more of a programme structure, so that each of our groups has got highlight reports that are reporting into the Borough Partnership Executive, which is just a, sort of a little bit more of a systematic approach. We've still got quite a lot of work in progress, things like chairing arrangements for all of aren't necessarily in place for all of the groups, but I think the main thing I would highlight is workforce is a real key priority for us. It feels like we're poised to really grapple with what is it that we are doing at a borough level to improve our recruitment, particularly into entry-level posts, to make sure that we're really going out to schools and colleges and communities and we've talked so many times about why that is a win-win, but we haven't necessarily had an infrastructure through things like a training academy to make that happen. And we're getting there, but we're just waiting for particularly an appointment of a person to sort of lead that work, which is in train. Engagement and co-design is another thing that we've got different approaches for different work streams at the moment, and we probably need to draw that into more of a consolidated. We can't have a one size fits all, but we do need an account of how we're doing this that runs alongside everything else that we present about the work of our borough partnership. I think that's probably all I would say. I just wanted Sarah to have a chance to talk a little bit more about the mental health.
Yeah, thank you, Rachel. It's been, I suppose all of this really is enabling us, and there's certainly a part within this around the sort of leadership and system leadership of partners and how we work best together in this space. And with the absolute focus on early support for mental health, we've been doing a range, I suppose, of enabling work streams in order to get us to a place where we have a really sort of deep understanding of the as-is position on the system, notwithstanding the fact we had a really good discussion at the last Health and Wellbeing Board on mental health, which really helped shape our thinking, alongside some sort of council-led reviews that are happening, and a lot of work that we're doing to embed sort of mental health in our neighbourhoods programme, and the links there across to Gary's World and BEH, or I'll have to get used to the new name as well. In terms of that's actually translating into additional resources as part of the community mental health transformation programme. We are and have agreed a high level approach to how we will start to review our Section 75s over the next six months, and that will be quite a significant piece of work to do that review. And then we are looking and I suppose taking that broader approach around, well, what does this mean at a borough level? What does it mean for how we may sort of test and learn an approach to future delegation at a borough level? And we're at a point where we're developing a programme plan to take us through in a bit of a roadmap to say these are some of the steps that we would take, and to do so as a partnership. And part of that is also taking on board the feedback from the review of council commissioned services and considering whether that's expanded in a more systems way, and whether we expand the scope of that, or do something that facilitates the conversation for us to really get to a point where we've got a shared ambition and programme plan in order to identify sort of key areas for development and as I say, potential delegation and in investment going forward. So that's just a really high level of where we're at, and completely aligns to that overarching approach in terms of a focus on mental health for the borough partnership exec.
Thank you. Thanks, Sarah. And unfortunately, I think Gary's had to leave.
Drop off.
Yeah. Otherwise, I'm sure he would talk to us about how closely he's working with you on these issues. It's certainly a huge priority for us as a local authority. And we've had some very productive meetings, and Beverly and I had a very useful visit recently to St Anne's site. So I think there's a lot of work to be done, but I think there's a lot of progress being made as well. So I just wanted to acknowledge that. I had a quick question myself, which is, just remind me, and I should know this, so I'm ashamed to ask, but so we have the clinical leads for each area and neighbourhood clinical leads. I think that sounds great, and really pleased to have you here online with us as well. So thank you. But just wondering, do we also then have a social care kind of community lead that sits alongside that? How does the governance work of that? I think that's important to think about.
So we mostly link with Chris as the principal social worker in terms of that kind of social work input. We don't have quite the same sort of named social work lead, but we do have the kind of service managers for children's social work and Chris for adults. So it's sort of similar but different. I don't know.
Well, yeah, but it's something that we're working on. So we'll be coming back to you via your one-to-ones and sort of in your capacity as chair, because adult social care at the moment are doing some work about what does that mean from a neighbourhoods and locality position, and how does it all fit together.
Yeah, I mean, just because I guess I asked the questions, hopefully it's obvious. It's about that equity of relationship and around, and after all, we're in an integration space. It's about us sitting together closely and everyone being really clear of who's working on what and why. So I had John first, and then I'll bring in Zena, if that's okay.
Thank you, Chair.
And
two questions. First one is directed to yourself, madam, and then second one to your colleague. First one is, I was diagnosed 2 years ago after receiving a life-changing injury at the Paralympic Games. 8 referrals went through the system from The Hague, Birmingham, and then into London hospitals. To date, none of them referrals have been done other than the Royal British Legion picking up the pieces and sorting me out. I just like clarity to prevent other people's going through the fishing like myself, whereby pain and suffering, but protocol and procedure being followed, and it's still disappearing through the net. That I just wish to highlight to yourself to prevent the suicide rate going up and families suffering trauma again. In regards to the discharge team, which you were talking about, discharge coordinators liaise with the 1400 line to say, we have a patient, that individual is being discharged. 13 months from the Royal London today, that's how quick it got them to get an OT out to me. I'm just letting you know the reality. Pasu, who is my OT person, could see carnage in her traffic lights, right, when she walked through the door. I was using equipment whereby I wasn't trained, wasn't skilled, wasn't competent. I was going by the discharge coordinators that weren't professionally qualified to say, this is the stuff you need to get. I'm highlighting it to you. There may be a staff shortage. MAT, the multi-agency team, are overwhelmed. The problem, on paper, it looks an easy fix. In reality, it ain't going to get fixed with a plaster. It's easy and simple. I'm speaking on behalf of the people I know personally. They are so overstretched and overworked. You ring up 1400 and say, can I have an OT here tomorrow? You got absolutely no chance. I'm being realistic with what I'm saying. So saying people go into hospital with life-changing injuries and then need measures put in place, it won't happen. It's easy and simple. Unless people know, senior officials in the local authority, whereby mountains can be moved, it won't happen. You'll be probably putting a backup system accommodation, and then you need adaptations put in, and then you need other areas of the community to liaise with the building contractor to adapt your property, and then that individual will be put back in there. Every individual on that run is not communicating. I'm not disputing Beverly. I've known Beverly for a long, long time, but Beverly being the figurehead is not aware of what's going on further down because people are not communicating through the chain of command. I'm not disputing you, Beverly. I'm respecting you. What I'm saying is the bottom line is if the people on the shop floor are saying, well, this person needs that, they pass it up to the next level. It's stopping at that next level static. Right? It's easy and simple. What I'm trying to address is if all areas, if someone that's had life-changing injuries, say my male colleague here goes out on a motorbike, gets T-boned, right? He now needs a completely remodeled, redirected property, carers and other people to sort him out. It's different areas of the local authority need to be directed at the same time. At the moment, every one of them is not communicating. I'm not finding fault with anyone here. I'm just trying to highlight that, say I worked in social work, OT, counselling and building. No one is using the same platform to communicate. That's what I'm trying to highlight, whereby the carnage me and my wife have experienced from 2007 to present day, I'm highlighting to everyone here that the little thing in the middle where everyone's meant to communicate from the branches running off it is broken.
Thanks for sharing your observations and experiences, John. I think it's really important that we hear those things. obviously this isn't the ideal place to deal with the intricacies of those cases. And I will bring Beverly in because we have been doing quite a lot of work on AIDS and adaptations, as you're probably aware. I think it'd be good to pick up the case just generally and think through things, and also think about joint health scrutiny as well as a place to take some of those perhaps observations around because it sounds quite like the very broad system as well. So it's probably a whole range of acutes involved in there as well. So that's my suggestion. But Beverly, do you want?
Yeah. So thank you, John, for sharing. It is very complex.
Yeah.
And I think you're aware that we are still significantly challenged post-COVID. Well,
yeah, correct.
Still in that recovery period. Correct. But we are working with our lead members, both children's and adults, to actually address the challenges within the sort of the AIDS and adaptation system and reablement. Yeah. I think it's important to note that actually the emphasis should be on the integrated response. So I know you're sort of quoting the local authority, but if you go back a few years, and I've been around a few years, I know that. If you went into hospital and you were T-boned, etc., you'd actually have rehabilitation, wouldn't you? Yeah. That you'd go sometimes if you're an older person, you'd go for convalescence, etc. Well, those services largely don't exist. So the whole system is challenged. And what we are desperately trying to do is to work better as an integrated system to make sure that people who are discharged from hospital, it doesn't help that the government's focus is really on numbers and getting people out of hospital and very often into bed-based facilities rather than supporting people back into the communities, which is what they tell us they want. So there isn't the focus on that intermediate care, that recovery, rehabilitation that we know is so important for people, and that is nationally acknowledged and recognised. And there's lots of efforts in that space to try to redress that situation. Having said that, there is some things that we can do as a local authority, and happy to take away the issues that you've raised for a greater sort of in-depth look and get you to contribute to how, given the circumstances that we are in, how we could have done things better, particularly in your position.
Thank you, Chair.
So no, really important, but I do think it would be good to pick up some of your experiences and talk to Councillor Connor, who chairs joint health scrutiny across NCL, just because there might be some interesting conversations.
It wasn't a personal.
No, it wasn't taken as personal.
No, I'm saying,
no one takes it that way.
We get it.
Absolutely. Yeah. I don't think, but so thank you. Yeah. Zena.
Yeah, I'm sorry, this heat has really, I'm not very good with managing heat, so I'm sorry if I'm going to sound that I haven't been following, but anyway, I think that was really interesting, and I can see you've tried really hard to integrate these sorts of boards and so on, but my question really is, how does it relate to the wider integrated care board, and how do we secure the funding? Because what the first presentation was all about, I have managed to weave it in, is about inequalities. So you're using a fund and a community chest and all those other means to try and sort of deal with the structural inequalities that exist across the 5 boroughs. So we know that Tottenham and Edmonton are going to be really the most deprived, I suspect, within the 5 boroughs. So my question really is, how can we use these mechanisms to extricate more money for the most deprived parts of the integrated care board area, so that we're actually structurally dealing with the inequalities, rather than, I'm not downplaying any of these efforts because they were really interesting presentations and really good projects and so on, but doing that like that won't get us where we want to be, which I think was what Lucia's point was. So I really am interested in that. And I'll give you an example. I was at youth justice. You'll know about this anyway, because it comes from your service. I was at a youth justice away day the other day, and we were talking about young people who had speech and language problems who are in the youth justice system. And then it got on to talking about hearing. And then I found out, which I didn't know, that in Haringey, we don't do school age audiology tests, which sounds balmy to me, absolutely balmy, given the fact that if you can't hear properly, your speech and language will definitely be impaired. And all this speaking, talking about speech and language, it's just a small example. So how do we build that in through these boards? It's so Byzantine to an outsider. You know, I'd like to know, Rachel, how we do that. In other words, how do we fight our corner? Just to cut to the chase, how do we fight our corner?
But I will try and respond to that. I mean,
then I can come in on.
Yeah, I'm really interested in other people's, and I'm not going to do the hearing testing specifically. I think if you start at the base, what we've been trying to do is get our own house in order so that we have an organised and systematic approach towards trying to know that we understand our communities, to know that we've got effective programmes targeting those areas of highest deprivation and our communities in most need, and we're doing that well. Then there is the tier, which is how do we, where there is some available funding within our system, how do we then use this to make the case to say we're doing really good work that needs to be sustained. We need disproportionate universalism. We need a bigger kind of chunk of the pie for particularly for Haringey, also for Enfield, where we've just got high concentrations of poverty. And I think I work really closely with Ruth and others who are really they're really trying to make sure that when there is any discretionary funding that gets attracted into our areas and our communities. But there is a wider thing which we find really difficult, which is the kind of broader politics, which is, this is back to the conversation that we were having yesterday, that you can spend lots of time arguing within North Central London for what is effectively a tiny proportion of the funding where we have any discretion, because the rest of the funding is not it is paying the salaries of people who are working in hospitals who we need to be working in wherever they are. It's not discretionary funding. So we're arguing over a very small amount of discretionary funding. And actually there is a bigger question about the impetus to focus disproportionately on, for example, a hospital like North Middlesex, which is right in the middle of Edmonton and Tottenham, as opposed to other trusts.
UCLH,
where they might have a lot of
research. That's what you're really talking about.
And
it's where it all is.
But when you look at the staffing of those two institutions, they are running on very, very different models. So I'm starting at the bottom, and we're just trying to work our way up. Is I think.
I suppose if I could come back, Chair, the question then arises: well, what do we all need to do? We have all these meetings, we've got all these boards, and we have our chief. For the way I see it, an integrated care board is actually an opportunity for Haringey, because while it was CCG, you're pretty much on your own. Now I'm pretty much outside all of this. I don't go to any of the really meetings I come to, or the SEND executive. And yeah, you were right about EHCPs and speech and language. So I'm not really engaged in it in the same way as Lucia or some other people. But it's patent. If it's patently obvious to me, because of the disparity, and I think a lot of it is to do with institutions which are so they're there and they have their budgets and they will fight for their corner, but actually a hospital like North Mid will always lose out because it isn't in central, it isn't in the universities and all of that stuff. Even if it's called North London, was it University? Isn't it North Middlesex University Hospital? It's not quite the same. And so that, I think, is our really big challenge, and we know that. I suspect we all know it. To tackle that,
I think you're spot on, right? Really, Zena. It's immensely challenging. Everybody in the room, I think, shares some of those frustrations. And ultimately, actually, Beverly and I and the leader were in a conversation about this very same thing. What's the issue? The issue is, do we get enough money for the needs of the people per person, for the needs that are here? And actually on the other side, if we alleviated some of the poverty and some of the other things that are really impacting people, wouldn't they be healthier and better and more well? So those two things together, have we got enough money to per person, given the levels of deprivation, but also tackling poverty. You know, and Health and Wellbeing Board is not a political space, but if I was in a political space, what would I say? I'd say, will the government commit to even saying that a proportion of what we do here that's money that comes from the ICB is spent on working preventatively, working early with people, and you can all answer that question as to what I think what's been said publicly or not. So in a couple of weeks' time, there's the ICP meeting where leaders, and I think I'll be accompanying the leader. And I think even though we're all in very different situations in NCL, we're all of that similar view around some of these matters. So, and we have certain different priorities, but that case, absolutely. And we also know that in other, to be honest, we know that in other regions, integration is working in a different kind of way. And we're seeing more delegation of funds, and we might think, well, we'd like to see more of that here. But I also really support what Rachel and Sora are saying, which is we're kind of working here in the best way that we can, making this solid grounding, building good relationships, doing the things that we should be doing, which can only but make us ready for a moment when whatever it is that comes down from on high. But you are right. And it's been the conversation I feel I've been having for 2 years, which is the money doesn't flow down, but we also have to have that data and that knowledge. And, and I think we talked about that earlier. We need to be able to say, look, this works, this doesn't, or we've tried this and we'd like to mainstream it, whatever term we want. But we also know our ICB is challenged financially and have been asked to make savings. So all of those things together make for a very difficult climate. Sarah, you want to come in, and then I'll bring Will in on the hearing test.
Jeffrey might have been first. So.
Yes, I don't know if you wanted to respond.
Well, I did in part, and to support some of what you're saying about those, the sort of wider structural funding issues and how we might approach that and what we might do. But I also wanted to pick up on the last point you made, which is we are doing all of this, but it would be remiss not to mention that the ICB is going through a significant change programme at the moment. And part of what our role will be, how do we have an aligned kind of resourcing structure that makes sure we don't lose the momentum with some of the borough partnership work. And I think that will be that transition to a new operating model for the ICB will be a key sort of area of focus for us over the next couple of months. As well. And then the further point on the place and space for some of those wider conversations is that there are sort of a couple of groups where we do that more strategic thinking, and also so that's a place editorial board for thinking about things like delegation and what that means for boroughs, and then the NCL local authority representatives are getting together more regularly at both an officer and sort of political leadership level to start thinking about those shared areas of priority and focus, which I think in time will come to some thoughts around some of those key points.
Thank you. Bill, did you want to come in briefly just on the?
Yes, thanks very much, Councillor Represent, for the hearing screening. So we have newborn screening. We don't have the reception screening in Haringey, and the other NCL boroughs do. The recommendations of the National Screening Committee are not altogether clear, but I think we just need to look into it, and we'll look at it through our kind of start well board and then come back to the board with.
Thanks, Will.
Can't apply for community chest.
Well,
I
think I don't think the finances is one thing. I think it hasn't happened for about before the transition of public health over to local authorities. Strictly speaking, it's kind of local authority responsibility, but we didn't get funding that came over with the transition to fund it. So there's a bit of history that needs unpicking. But for me, it's like whether it's the right thing to do for our population. We just need to intuitively it feels look at that. And I think the screening committee recommendations, and we are actually picking people up. I think the latest data was we were picking up similar numbers for hearing screening through, for example, health visitors, speech and language assessments, etc. So there's other ways apart from the screening to pick up those people. It's a bit of complexity there.
Right, and you'll bring that back to the health modelling board, so that'll be really helpful.
I think
So
that'd be
thank you.
really interesting thing. I know it's like in the scheme of things, not a huge issue, but when we think about all these things we're trying to do with safety valve to ameliorate, people going for EHCPs later because we have to bring them down. Anything that identifies early problems that then some earlier resource could assist would help us out enormously.
Taken. Thank you, Zena. That's really helpful. Jeffrey, and then I'm going to move us on from this topic.
Thank you, Chair. Thank you, Rachel, for taking us through the updates. And good to see the structures developing and so forth. I think I've got 2, maybe 3, Chair, quick points. The first one was my second, but I'm going to make it fast, which is around delegated decision-making at place-based. Because I think Sarah made some reference to lots of changes going on within the ICB. I'm sure all of that will consider some of the decision-making and where they are taken. And I think it's important that whatever decision we can take at place level also gets factored in at some point, because that will address some of the things you've been talking earlier on about some of the funding and so forth. So that's the first point. I think the second point is, which I've made before, but I haven't seen any action on it, which is this, that this is all about population health, is about health inequalities and so forth. And I think if we're thinking of the structure, surely we should be including the kind of other specific work, such as the coordinating group or indeed the racial equity group work that we're doing. And just to let everyone know is that all this came through the pandemic. And so the racial equity in health and social care looks at from an ethnicity perspective, really. So we're trying to look at all sorts of things that impact and brings on inequality, whether that's around mental health, that's around maternity care, whether that's respiratory thing, or cancers, all sorts of things around patient experiences. And I think I would suggest those pieces of work and thoughts needs to be finding some way of being fed into this, whether it's a dotted line, a bold line, but we must see something. So I'm going to make that for the second time, and hopefully that gets added in there. Otherwise, it looks like some of this really important work is taking place over there and nothing to do with what's happening here. And I think that's not justice. So that people like Nadine, you're in that group, I think a few others in. I know, Rachel, for some historical reason, you don't seem to be there. We'll try and correct that, I think. So you're cited more there. And my third and final point is there's been reference to co-design and co-production or engagement. And there's a fantastic piece of work going on. There's a launching of a toolkit that has been one of the 5 thematic work as part of the Healthy Neighborhoods. So it's on the 10th of July, led by Public Voice. We are working with them. I know that the invites has been going out. It's a bit limited, but Chair, we made a specific point that you're invited. I don't know whether that's come through your way yet. And if not, then perhaps that needs to be done. So, and then is later on, to borrow your word, are we mainstream co-production across the piece? Thank you.
Thank you. Thanks, Jeffrey. No, I don't think that has come across. I was going to say, oh, it might be a really exclusive invite list, so I haven't been invited, but let's just check that. So absolutely. And I only hope that the diary isn't terrible, but it probably will be, but not to worry. On your point about the connections and what have you, and decisions being, I suppose I wanted to share my own pain, which is that's how some of, on the bigger, wider ICB, us lowly politicians who are quite insignificant and unimportant in these things, sometimes it might feel that way too sometimes, that we're not, or sometimes we find ourselves as the only person in the room saying certain things, one or t'other maybe. So I share that, and I'm sure the team will pick up how we can at least make sure those links are stronger. Sounds like there's some groups that Rachel should be on perhaps there, but let's make that stronger. Did you want to
So,
say?
I mean, just to say, you're totally right about the racial equity group. We just need to do the work in practice about how do we get the feedback loop, and we just need to reflect it in our structure. So sorry we haven't done it, but
there's a few things like that sit slightly to the side that we want to bring in, but we probably just need that conversation at the borough partnership exec, Jeffrey, to get the mandate to do it. So I think we could we could look to have that conversation at the next meeting. Workforce is another one. It's embedded, but actually, do we want it as a standalone priority area connecting in? So yeah, I think it needs a conversation at the exec before we can show it in a structure.
Thank you. That's really helpful.
Yeah.
And I just wanted to add on engagement and co-design. I guess I felt a little bit like there's a bit of inherent connection between that and then the next item on the health and wellbeing strategy, and because but Will's going to talk to us about that, and then I'll say more about. But I didn't want to lose that and think that that co-production, co-design should be intrinsically linked to that. So on that note, if we're happy to,
well, I suppose it was just the question that we were asking of the board, which I think we're getting the feedback and building upon, is endorsing the approach that we're taking with the borough partnership as a direction of travel, where the health and wellbeing board are happy with the way we are planning to progress things.
If everyone else is happy in the room, and taking on board some of Jeffrey's comments, John?
Yeah, just what I was saying. The only thing I can place as a recommendation when you go back to your mental health colleagues is after hours, can you put a recommendation in? More people required for a crisis team, please. Thank you. Thank you, Chair.
No, thanks, John. It's honestly, I honestly haven't briefed John, but it's really topical because that's exactly what we've be really pleased to know. Beverly and I had a meeting a few weeks ago, and Gary, where he's still on, would attest to this. And it's exactly what we talked about. We actually talked about 24 hours, and we know in other boroughs there are services that run, especially at night.
I weren't disputing my GPs who are on the screen or any fellow colleagues. What it is, the GP gets called out of hours, he calls a police officer, and then they're there, endless amounts of waiting time, because Chase Farm, where the crisis team run out from, they are limited to 2 vehicles, a team in each, and that's covering multitude of boundaries, multitude of boroughs. That's why I was highlighting. Thank you.
No, thanks, John. And I can't tell you, I think I probably discuss this every week, actually. So Beverly, did you?
No, I just wanted to respond just very briefly. So the right care, right place, I think I've got that right, is a subject that we've also spoken about, and there's something around how we need to come together collaboratively with the police to work through how we respond to the directive that's coming into place.
And there's a huge London conversation taking place about that, because actually we were all facing some of the same challenges. Thank you. But I'm going to move us on quickly to item 10. Will.
Yeah, thanks, Chair. So I'm Will, Director of Public Health for Haringey. For those of you who don't know me or weren't at the start of the call, I've also got Miho Yoshizaki, who's just joined, and she's on the pathway to being a public health consultant, which is in essence the work. So she's joined the call today. Also, just linking back to the last point, I think I wanted to link back to the meeting. We will send out the papers from the last meeting where we discussed some of the things we've actually talked about today, and then I think between the Health and Wellbeing Board and the Health and Wellbeing Strategy and the Population Health Strategy. But just on the Health and Wellbeing Strategy, so I've spoken about this before, both here and at the Borough Partnership Exec, but just a reminder that we are going to refresh our Health and Wellbeing Strategy, so have a 4 or 5 year strategy starting from the beginning of next year. This is really important for us because it will capture some of the things that we've talked about today through the Borough Partnership, which we know are established priorities like tackling inequalities, tackling racism, mental health, speech and language, but we also want to have a process of going out and speaking to residents to say what else would contribute to better health for you. And we want to do that over the next 3 to 4 months. So we're leading that very much in the public health team, and we are going to have a process whereby we speak to people that we don't often speak to, and try and find some groups. So I was really interested hearing ABC parenting because I was interested, had a light bulb. We could go and speak to them and ask them that question. You know, what impacts health for you? What are the then we know there are various communities that came up as well in Tottenham Talking presentation and the ABC parenting, where we don't normally speak to people from Eastern Europe, for example. We haven't involved the Orthodox Jewish community a lot in our general engagement around health and well-being. So some focus sessions with some groups that we really want to speak to and find out what better health means to them. And then I think as we go into September and October, some broader sessions like we have done in the past in places like Tottenham Leisure Centre. I was in St Anne's Library. I'd not been there before for my sins for a Windrush event on Friday, and just speaking to that community again. Don't normally have conversations with that community, so just some of those opportunities. And what I wanted to do today was just update the board on this process, and I guess I asked for help in two different areas. One, we may need your help to identify groups, and we have those relationships around engagement, so I'll be reaching out. But also it's for the board to really take on what we hear and what that feedback is from residents. We have this ambition to build co-design, and we are doing that to an extent, I think, lesser or greater extent in all of our programs in the service delivery. But actually of residents in setting some of those priorities as well. So that's the update, and of course we'll continue to. But I think we're looking to that engagement. The next board is in September, so we won't have completed the engagement there. November we should have completed the engagement process, and then look to developing that into our strategy and action plan. First one in 2024.
Thank you, Will. And I just can't stress how important I think this is in helping us, give us the ability to go out and deliver what we need to deliver for residents and the community defining what better health means, and helping us with the what and the why and the who, you know, and the how. And I think that will really strengthen, but really support some of the other conversations that we're having. We've been talking about funding, etc., and help evidence and support that. And it's just an opportunity for us to all coalesce around all the things that we know in a really positive way, and go out and then talk to people. I think Will's right. It's a really good opportunity. I've got John, and then Polly, and then Dina, and Jeffrey.
My fellow colleague. Yeah. The only thing I can say from a previous individual meeting held with a local authority in our community hall, be prepared for a mountain load of negativity. I'm not being personal to you, so that do not take personally. The badge around your neck, you'll be treated like the enemy. That's all I'm saying. If you go in as a neutral, right, and listen and not be directive, right, the elderly ladies will treat you with respect. We had 4 individuals from the local authority there. They were literally being murdered by 20+ women, right, whereby they were trying to dictate to them, right? If you come in with the same what a class as what they've listened to previously, and not with a clean page, clean slate, you will be assassinated. That's all I'm saying to you, sir. For a simple reason being, the elderly ladies' mentalities, they've seen it, they heard it, they don't want to participate in it.
Thank you. We hear that a lot.
That's what I'm saying. If you come in with a fresh page and a new chapter, right, and say, this is what I want to deliver, I'm not going back, this is who I am. Talk to them on their level, where they dialogue to you, and you listen, take on board, and then give them a dialogue back. They will respect you. If you don't listen and just keep throwing at them, they will just murder you on the scene and walk out.
Thanks, John.
Yeah.
No, thanks. Although slightly, no one get too anxious about the idea of it.
Sorry, Beverly knows what I'm talking about.
Yeah.
Metaphorically speaking,
exactly. But I think that I think that's precisely what we are doing, is going in open to listen and actually just have a really good conversation about what better health means and how to go to people. So I think no fear, John. I think we're on a real co-production journey ourselves, but I think we get some of those basic principles. I think you're right.
Yeah.
Polly, and then Zena, and then I'll bring Jeffrey.
Just to soften John's blow there. We work very closely in Public Voice with lots of groups in and I think I may know the group that you're talking about. And so we're obviously there to work with you to kind of help you engage in those communities, but there's also there's the kind of usual groups like the Joint Partnership Board, which which are already very much part of the process, but I think we do need to reach beyond those groups to more grassroots groups and community voices that are not as heard, and that might come through some individual work via social prescribing or community navigators that are coming across particular individual issues in the community that we can't actually resolve. The offer's there to kind
There's
of
something about collecting, isn't there? Here's the kind of the feed here are, quite often when I speak to someone, they tell me about this issue and we don't know where to place that. So something about harvesting that info
That's what
might already happen.
That's why I become a digital champion. A lot of people on my estate are not aware of iPhones, computers, or laptops. That's why I become a digital champion. So whatever issues they got, I can address them for them, and then give them the feedback.
Thanks, John. That's helpful. Thank you.
Thank you.
Thanks, Polly.
I just got a couple
Lena.
of points. Number one, I agree with you. I think this is really important. I'm pleased you told us about it, because I think if we want to do a camp effectively, mount our own campaign or pressure in order to redistribute whatever money there is within the ICB, we need the evidence. We need a good base, and we need a good strategy that starts with people telling us what the issues are, because it's not like they really don't know. It's there's a big political enterprise at the top, isn't it? So I think it's really important that we get the people's voices, and that it is creative. Perhaps think for more creative ways by, I don't know, having some videos or some collages of people talking themselves. And the other thing, I agree, there are loads of little pockets of people, this borough, because it's so good. Like at the Family Hub today, there was the Wolves Corner group.
Yeah.
I know you spoke to them about the Latin American stay and play. Now there is a group you don't ever talk to, the Latins.
Yeah.
And there's a huge Brazilian and Colombian community around South Tottenham. And I think where I'm going is I think there is a lot of local knowledge that actually councillors have. Partly I'm talking about myself, but also I know Lucia has lots of local knowledge, and so do our colleagues like Ibrahim. Our colleagues
Exactly.
who are on the council have local knowledge, and I don't think that you pick people's brains enough of what they know. So we come in, and Lucia sort of said, I feel that you're very relevant, Well, I can't remember.
No, yes, I was being sarcastic.
A bit of a decoration. Yeah. I could be a bit of a decoration. But actually, if you want to pick people's brains, they'd be only too pleased to tell you what they know, who they know, and someone like Ibrahim Ali, like, so well connected in the Somali community. Anyone you want to know, he'll know. And I think that you underestimate those links, and it would be quite important to use that if you want to find little groups, like Ruth Gordon, she knows all the Latin American community, things like that. And I think missing a trick. And I suppose the other thing I would say, and is it John?
Yes, ma'am.
Yeah, I was going to follow up a bit about John, but from a children's point of view, one of the things that really worries me in the borough generally is the issue of complex needs. I don't know whether we have a higher percentage of children with complex needs, but I think complex needs, they draw on all those services. And I wonder whether as part of that, we couldn't just maybe have a focus group as a little plea with parents of children who have complex needs. I don't think their voices are heard very frequently because they're drowned out by the more articulate, the lobbies like the autism lobby. Yeah. They really are. And I think in special needs, there's a lot of hierarchy of campaigners that sit, it's not one size fits all. Send Power. We've got this big parent care forum now, but actually people like the parents of the kids at the Vale, you don't hear from them. And yet they're massive consumers of resources. And I do think we could perhaps look at the strategy and just take some more little tiny, unsung, unheard of groups where there is a high need, high expenditure. Am I banging on a drum that everybody agrees with?
Yeah. So, and I think when we talk about inclusion as well, hearing those voices and hearing what's the definition of better health, what's good, what looks like good.
Yeah. And
Ollie, did you want to come in on that point, and then I'll bring Jeffrey?
Yeah, it's just that I get the feeling that true co-production is actually bringing people along with you rather than just consulting with them.
Yes, I agree with that.
And so it'd be good if you think about a strategy where you do consult, but you also have a framework to continue that engagement and follow up. And because a lot of people walk away going, that was lovely, loved that conversation. We'll see. And I think that it's the we'll see that we need to kind of get over.
So I think the answer a little bit to that is that if we hear and then we use that to put a plan together, then this group, we then will be reporting on that plan. We'll be looking at what that means. And then it will be about how we engage, and I'm going to come on to that a little bit, but how we continue to engage and how we invite. Some people may want to follow that journey, and it's how we invite them in. And actually, for a while, I've been unhappy that we've got John today, but we don't have as much engagement as we could with Health and Wellbeing Board. It's something, there's some new, I was going to come on to this later, but I'll mention it now. There's some new guidance on Health and Wellbeing Boards and opening up more. So we've got our Community Health and Wellbeing Board, which was running separately, which felt at times a bit duplicative and a bit like we didn't quite know how this is working. So the vision that we're proposing is that we welcome in that board more into here, and that we share the space together. So that's also an opportunity for people to follow what we're doing and how we're responding to that definition. But and I think also articulating really strongly, this is what what you all have said defines what better health is in Haringey, and articulating that's really important.
I think that's a really important point. I've drawn a parallel. Later, you sit on the SEND exec, don't you? Inviting in the chair of the SEND exec of the SENPAR has made a transformative difference, because there was I know exactly what people are thinking. I think there's some type of secret garden here, when there's some sort of conspiracy of these professionals making these decisions, and you lift the veil. There's nothing to see. It's the Wizard of Oz, really. There's nothing there, really. There's no levers. Everybody's just trying their best, and they're trying to work it out and putting the minutes on the council's website. Oh, you look back. Why weren't they on? I remember saying to Grandma, I don't understand why they're not on there. What's the problem? Because there's nothing particularly secret. It's no big confidential thing. It's just people trying to work out how you problem solve, how you do things, and it has made a big difference, hasn't it, Rachel?
It really has. Really has.
But then we've got the opposite here, which is we have a public meeting, which is video and now helping facilitate online, etc. And actually we talk about some quite important things and relevant things here. So making sure people have got the chance to bring their voice to that table,
which is good.
Feels important.
It's good.
I'm going to bring in Jeffrey because he waited really patiently, John, and then I'll bring you in, Jeffrey.
Thank you, Chair. Thanks, Will, for the introduction. And I think the points have been made, but I'll just try and briefly put it from another perspective, really, which is it would be good to kind of see, because I think John is right about the approach that we need to take. It would be good to see some kind of engagement strategy that we have in mind. So how, who, when, and all of that stuff, we are going to be reaching these people. So that would be a good thing to see before we actually launch into it. The second thing is also, there's a lot of this kind of work been going on for the last 6 months, even the last 1 year, I think. So to what extent are we going to join up and learn from, work that's being done? Because some of these groups, take Somali women, for example, they've been kind of consulted a lot, I can tell you that. And this applies to all the other groups, whether it's Polish, Latin American women. So, and there's something about, they might just say, we've just told someone about all of this, and you're still coming back. So I think it's about collating what the message is and where gaps are, and then we try and fill those, I think. So example include co-production theme as part of the Healthy Neighborhood. They've been talking to all these grassroots organizations and residents. Something called, what is it called? Community Action Research, funded through the ICB, has done similar piece of work years, I've done a lot of work around mental health as well, working with VCS groups. So the point I'm trying to make is let's try and use what we have and then try and build on that. Lastly, the strategy needs to look at how we reach some groups. Language is a particular issue. So, for example, this morning, you and I and Councillor Brabazon were at this fantastic launch at the Triangle for the Family Hub. If you just look in around there, lots of languages there, not just, Orthodox Jewish, but also Latin American women, and some of the status of the resident, needs to be navigated very sensitively, if you get me, yeah? So there's something about how do we reach some of these communities and get their voices. So a strategy is the word. Thank you.
So I agree with loads of the things that people have said, and I really both using what we already know, and I think it will be a really good, having this will be a really good basis for us moving forward. I'm really conscious if you go and talk to people about anything, right, how to, what is better health for you. I mean, I nearly didn't get here because my next door neighbour collared me about, access to phlebotomy. We will get a whole load of things about, I just want to be able to get hold of my GP, never mind, and that is better health, or correspondence. I don't know where I am in the waiting list, or blood tests. I've lost the plot in how I access actually a blood test, and I just wonder whether we need to think a little bit about how we might follow up with colleagues who are able to provide a bit of that sort of just direct comeback to people on how things organised at the moment. So I don't want you to, I think one of the things that can be really difficult is that you ask people about, and then they tell you things and you say, well, I'm more mean in a kind of conceptual sense, what does health mean to you, not how do you access? And actually what people want to know is, how do I access? So I think we just need to think about what is our response when people just have lots of questions about how they get stuff.
Yeah.
I think you're also right. I'd add to that, also right, that when you come into a space to think big, you need to have somewhere to leave all those things that are the really pertinent worries. And then once you can say, okay, right, I'm going to find out about phlebotomy, then I can be unburdened, and then I can open my mind and go, well, in the ideal world, I would go X, Y, Z, or I would do this, or I'd be able to share this with my family.
Right, that's answered your question in one. That's why I become a digital champion. There's not enough promotion on that, and that's why people are left with a burden. I got 34 on my estate, and I'm the only one that's IT literate. That's why people literally, if they need an appointment, they need how to get there, they need to know what bus is. That's what my job. In regards to my fellow female colleague down the end, it's the silent people that are not being recognised. The bigger people with the bigger outlook on life, and not the small little ones, is what we've got to open up and find out what they require, what they need, and how we can get around it.
Thank you, John. Thanks.
Thank you.
I've seen her, and then that's going to be the last one.
Sorry, Beverly. Sorry. I think you'd have a strategy which is really just like looking at health, like dominance, inequalities, and so on. But actually, I think it was an Ian Bevan, and he was also Minister for Housing, if I remember rightly from my history of the post-war period. And I think that tells us something. So I did write a little note there. I think it would be worth, in a broad strategy, being a bit creative maybe, and thinking about some issues, because we're looking at housing in this borough now. We have a housing improvement board. We have to look at housing allocations. There'll be a review of housing allocations, and that feeds very much, I think, we know that if there was decent housing, a lot of health problems would evaporate, wouldn't go completely, but that'd be less, because you wouldn't be living with chest problems and mental health and depression because you're living in a terrible place and all the rest of it. We know all this, but I think it's worth articulating it as an ambition, as part of a strategy, that we understand the wider focus, and to feed in, particularly, I think, on the issue right now around housing allocations. I think it's such an important issue, because someone at the event this morning, 3 children, 2 with special needs. She's in band B, theoretically because she's adequately housed. But of course, one's epileptic and one's autistic, and don't need to spell it all out.
Yeah.
You know, that sort of thing. That all it causes is more tension and more pressure. You know.
So I think if we interviewed a family like that and they would say, well, better health for me would be being able to manage my family life better with more space so that my children can sleep in separate rooms so that they're not waking each other.
And we are
that
looking
sort of
at
thing.
different housing allocations. Well, we will be. We are. It is. And I think that's as much a public health as, you know, I think you have a really important role. I think public health has a massively important role in all of this.
Can I just second that by saying the biggest issue that our social prescribers, so our social prescribers are working from directly from primary care with patients. The biggest issue they're working with is housing.
Yeah. And
that is what's being fed
We
through
hear that wherever we go.
Wherever you go.
I'm gonna have to. I think we're gonna have to wrap up. I'm really sorry.
That's all right.
It's the end of the meeting. Bill?
Can I just come back just on an ask? Because I think one is to kind of manage the expectations of what we can do, because I think what we want to do is complement what we've done before. I think we could achieve a lot from kind of event that we've had in Tottenham before, where we have been able actually to have all those when people have said, oh, can't get access, then we've been able to respond and then complement it by speaking to groups who may not attend that kind of workshop, for example. And then another ask is just the next Health and Wellbeing Board is not till September. So I heard from Jeffrey, you know, it'd be useful to see kind of a plan of who we're going to speak to. So just an ask that we can send that out via email rather than sort of and get the next board.
And I think it's for all of us in this space and those who aren't online either, to kind of pick up and make it what we want it to be. Because I think actually there's a good amount of consensus in the room about what we'd like to see. So then we're all members of the Health and Wellbeing Board, we all in our own way and in our own sphere can do that and can pick that up. So thank you, everyone. I don't think we have any other items of urgent business. I just wanted to flag that we have always this moment at the end of meetings with future agenda items, and actually, Naz, I don't have the date for the next meeting now on the top of my mind.
I'll get that for you now.
Flag that, but just to flag to everyone, I'm not going to go through. There's a list of things there, and there are some other things we need to bring to the meeting in future. But please don't hesitate in getting in touch. John?
The only thing I'd like to bring up, which collates together my 2 female colleagues, the female on the end and this male, is it possible to bring up substandard living accommodation whereby lack of support from other departments in the local authority, causing mental health and anxiety with the 2 people there, nothing happening in the communication with the female colleague in that department, and this the male colleague, whereby everyone it's now mounting up on the departments out.
Yeah, so we've actually talked about housing possibly. It's not on that list, but we have talked about the impact of housing on health before.
Yeah.
I know that the council has a housing improvement board which looks at some of the issues you're talking about. But you're right that we could certainly have that as we could talk about housing and health.
That's yeah. I'm not talking about segregate. I'm talking about running like that. Sorry.
Okay.
It'd be really good to bring what Ruth was mentioning back as well for the next meeting. I think Ruth was mentioning that approach that they're taking around how to measure and think about the modelling that a team are doing. Yeah. That would be really timely because I think it would help us with some of the our partnership thinking.
Okay, I'll leave it between you and Naz to find what the
right. We'll come back to you.
That item. Yeah. Okay. Okay, we're 2 minutes over. Thank you very much, everyone. And see you all soon.
The next meeting is the 20th.
20th of September. Yeah. Right.
Yes.
Did you ask them?
Can you pass my data on to? I can't think of the lady's name.
Naz, are you able to do that? Are you